Hello, everyone. Thank you for joining the webinar. We're going to give everyone a few more minutes to join. Okay, Neil, I think we can get started.
Good afternoon, everyone, and welcome to today's webinar from NARC that is entitled Health and the Built Environment. My name is Neil Bomberg. I'm a senior policy analyst with the National Association of Regional Councils, and I am delighted to welcome you to this webinar that we hope will provide you with some important insights into many of the major public health issues regions are confronting today, including affordable housing, equity, water and air quality, smart growth, energy and climate change, food distribution, and how to address them. The three regions participating in this webinar, and they are the Metropolitan Area Planning Council, or MAPC, out of Boston, the Delaware Valley Regional Planning Commission, DVRPC, out of Philadelphia, and Eastgate Regional Council of Governments, better known as Eastgate, are taking over many of the functions once considered the privy of local public health departments or environmental protection agencies, and expanding the focus from one that is local to one that is regional. Our presenters today are Barry Kephart, Director of Public Health Department at MAPC in Boston, Sarah Wenger-Dougherty, Economic Development Program Manager at Eastgate in Youngstown, Ohio, and Sarah will be joined by Eastgate's Executive Director, James Kinnick, and Patty Elkis, Director of Planning at the DVRPC in Philadelphia, Pennsylvania. I just want to let you know that there will be time for questions and answers at the end of the webinar. So please be sure to enter your questions in the questions box that appears on the GoToWebinar control panel, generally on the right-hand side of your screen. And at the conclusion of their presentations, we will engage those questions and try to get you the right answers. And now I'd like to introduce our first panelist, Gary Kephart, again, Director of the Public Health Department at the Metropolitan Area Planning Council in Boston.
Thanks, Neil. It's great to be here with you all, and it's great to be here with everybody else on the call too, who we joined not too long ago down in DC to have a similar conversation. What I'm going to talk a little bit about is the Metropolitan Area Planning Council's public health work, how we got involved with that work, what we see some of the benefits of it, and just kind of a little bit of a quick overview of the types of work that we've been able to house under our public health team here at MAPC. What guides our work as a regional planning agency that's serving Greater Boston is our regional plan Metro Future. And these are just some samples of the vision, elements of the vision for the MAPC region. And people really began to ask, if you're talking about these things and talking about things like the built environment, we need to think about the outcomes and how that affects people's lives, and in particular, how it affects the health overall of the region that we serve, but especially for those who bear the greatest health burdens in our region. And why they said that is because what we continue to find out is that we can think things like going to the doctor or what we're born with really affect a lot of our life. And at an individual level, that's 100% true. But when we pull back and look at a whole community, a whole region, what we find is that it's really the social, the physical, the behavioral environments that are around us, the things that are really having an impact on us, and figuring out whether or not that keeps our communities, our residents well, or puts them in positions where they might get sick, and potentially add that on top of other burdens that they have in their lives. The other piece that continues to increasingly figure into that is that we're seeing more and more public sector budgets, whether it's at the federal, state, or local level, be swallowed up by healthcare costs. And this is just an example of what we see in Massachusetts at the per capita level. Those costs, even if they may be beginning to level a little bit, are still increasing and just increasingly costing a lot. And so if medical care, which receives a lot of our funding, isn't responsible for that, how can we work upstream and begin to think about how we can affect the built environment, physical and social environments through the work that we do? And I think most importantly, I think as this plays out, and you can see examples of this throughout the country, is that in places that are only a short distance from one another, great differences in life expectancy. So people being born at that same part in time can have somewhere between 15 to 20, some cases even 30 years of life expectancy difference of being born at that same point in time. And so knowing that we can and do have a role in this, MAPC decided to take on looking at how is the intersection of our regional plan, those health issues that we confront, and the capabilities that we can bring can allow us to contribute to this conversation and recognize the influence on public health and health outcomes that planning can play. And so at that intersection, there's a lot of places specifically that we think we can work, whether it's beginning with a disease focus, so thinking about people who are dealing with unhealthy weight or issues like asthma, thinking about the injury context and how our transportation planning affects that, knowing that employment and income play a big factor in people's lives. I think as you alluded to, Neil, knowing that housing, whether it's stability or the fact that there's choices for people at different affordability levels, that being a big part of it. How our external environment, what we're breathing, what we're being exposed to is affecting us. And then ultimately, how can we begin to add to that body of literature that speaks to how we can affect those health outcomes? As we started this process, we also saw it was a great opportunity to build a lot of new partnerships that we don't have now. And so often, as a regional planning agency in Massachusetts, we directly interface with cities and towns, a lot of municipal officials, people at the state level, but there's a number of partners that we didn't engage with, and the public health team allowed us to begin to connect with those better. So connecting with people who are directly working in the medical industry, like hospitals and health systems. Similarly, connecting with our departments of public health, whether at the state or local level. In a unique situation here in Massachusetts, we don't have county governance. And so really we have these 351 local boards of health in Massachusetts, and then we have our state department of public health, and we kind of be able to connect between them and connect with them. But we also wanted to think some of the other institutions, whether they're contributing to the literature base, so like our academic partners, and we're fortunate to have a number of universities who focus on that in the Boston area, but also to working with those people who are paying and are concerned about how much the healthcare system is costing them, people like insurers and the CDC. So it really allowed us to build a whole new set of partnerships in there too. So I'm going to talk a little bit about how now we decided to take that role, take those connections, and leverage it into a couple pieces of work. And so one bucket of our work is thinking about what we call healthy community design. And from that perspective, we're thinking about how do we influence the built environment. So whether it's the transportation system and creating opportunities for people to be physically active, engage in active transportation, like biking or walking. What are we doing to call this out at a policy level, especially at the local level? So thinking about planning documents, comprehensive plans as essentially policy statements and driving hopefully changes, whether it be in zoning or other regards or housing production. How can we begin to influence that? One really great example of that is work that we've been doing around the intersection of how we think about parks and open space and how we kind of connect that to the work that we're doing. And so here's just an example when we think about what parks and green space have been cited or been noted for associations with. So whether it's people being more active, healthier weights, less stress in their lives. It's actually been connected to other things too, directly at the physical level. So essentially children being born at higher birth weights puts them at a less risk for other lifelong health issues. But then overall, essentially kind of life expectancy. And so we wouldn't say any of this is necessarily causal or forcing it, but the strong associations between having these exposures from the green side. And so how do we begin to cite that within planning documents that we use? And so a colleague of mine, Sharon Runn, helped us kind of put that together in a way that we can begin to talk about it through a lot of our planning documents. And so here's an example of what we would consider a pathway diagram, but it's a way of us beginning to frame the conversation around how do we take these public health connections and talk about them, how much open space is there, what is it like, can people access it, and making those connections to what happens in the immediate surrounding areas, and then ultimately what are the health impacts, and beginning to use that to drive conditions about what we designate for open space protection or for parks redevelopment, and really being sure that we're helping to serve those health issues and those health outcomes we want to see. Another big piece of our work has been focusing on health impact assessments, and this has really worked when we know that there's specific decisions at hand that aren't considering health. And so in particular, what we're dealing with too is a lot of transportation decision-making that impacts health, whether it be any of these factors that you see on there, to its physical activity, the emissions that we see from it, the injury that may result from crashes. And you can see the various ways you can map those connections, and all these are coming from some cited source and research around the connections. And so we were able to take those particular findings and actually take that investment when here in the Boston area, the transit system was being proposed for severe cutbacks and fare increases, and be able to bring into that conversation information about the fact that we're not just worried about the financial implications for the system, but we need to think about the outcomes that it's going to drive as well too. And so in this particular case, able to talk about what does that mean for traffic and what we'll see in terms of lost economic opportunity or additional emissions, what will we see in terms of the lack of physical activity, because we know people who take transit walk more than those who drive. And so losing that physical activity at a daily level, and begin to play out those scenarios, not only in the context of just a pure financial mechanism, but within the sense of what does it mean on the financial side of cost of health and cost to the communities. Another piece that's really been big for our work too is really adding to that literature base. And so how can we begin to contribute not only within planning and policy decisions, but how can we continue to use work to inform essentially the data that people need at the local level to replicate our work or to kind of participate in some of that work. And so here are just some examples of work that we have done. In particular, one piece we've been trying to pilot and innovate around is how do we get better measures of area level or neighborhood level rates of physical activity, so that we can understand, are we making investments, things like complete streets investments, shared use paths, are they actually resulting in the physical activity changes that we want to see? And so we've been actively piloting use of manual and automated counters within certain neighborhoods to begin to sample and say, hey, we are seeing changes in physical activity, and we're also seeing this much or this less walking occurring. So again, it helps us to understand what projects we're doing, how they can be more effective, but also that we're seeing those outcomes that we want to see from the physical activity and health level. Another piece that I noted earlier is that we're making these connections, and making connections not only across municipalities, but through other partners as well too. So thinking about how do we work with our State Department of Public Health, our friends in the medical field. And here's just an example too of another pathway diagram when we're talking about what is it like to connect investments in housing instability. So where people are not able to find housing, people who are feeling insecure in housing, people who may be homeless. And this represents a piece of work that we're using as part of working with a hospital that's taking community benefit dollars and actually investing that in housing stability and actually a little bit of housing production, really thinking about people who are in unstable condition and who may actually end up being high utilizers of hospitals because they don't have that stability in their lives. And then lastly, we've been really interacting at the policy level as well too. And this has been thinking about what at the state level or local level can we use to kind of create sustainable changes. And an example in particular, we've been doing a lot of work around there is really thinking about what do we need to do with our food systems. And that gets at issues of food availability, food access, food affordability, and thinking about it within the larger framework of where that food is coming from, how it's distributed, and how we deal with any of that waste. But we see these connections, first often housing being a strong one and physical activity, but nutrition being such a big part of all that too. And so we've been bringing that information together to figure out how we can expand our communities and thinking about local food, regional food, and how those systems are working together. Something, and I think Neil referenced this earlier too, increasingly becomes important as we think about a changing climate. And so we've developed things like toolkits to be able to help people understand what are some of the municipal strategies that you can use and intervene with. We've developed a number of healthy community design toolkits or contributed to ones in the state. And that's helped us, again, provide the specific tools for our municipalities. I think the last note I just wanted to end on is talking a bit about how we've gotten into this work, what we're doing. But just wanted to end on the note that one of the reasons that we see this as being really important is because what we're seeing is that our medical systems, those are who are really, really concerned with our medical care costs, as well as shifts in terms of how the health systems are working, particularly as they move from less of a fee-based to a value-based system, that they're beginning to make investments that move more into the territory we as planners or the planners we work with tend to deal with. And so that's why we think it's really important to do this work so that we're not only addressing the issue now, but that we're preparing our partners, our natural partners in cities and towns and neighborhoods to be prepared to engage in these processes and for the most part take a leadership role in understanding where these investments go and how they're going to really bring to us a healthier set of outcomes. So hopefully that helps frame up a bit about how we approach this work and some of the work that we're doing, the reasons for us doing it. Now I'm going to hand it off back to Neil and my colleagues on the call for them to share a bit about their experiences.
Thank you, Barry, and I'm sure you've generated a lot of questions, but thank you for that very informative presentation. Our next presenter is Sarah Wenger-Dougherty. She is the Economic Development Program Manager at Eastgate in Youngstown, Ohio. And as I mentioned, Sarah will be joined by Eastgate's Executive Director, James G. Kinnick. So, Sarah?
Yeah, thank you, Neil and Nark. I really take this as an honor. It's pretty cool to present with some larger MPOs that I've looked up to and I try to steal ideas from. So I'm glad to have this opportunity to share ideas from us. Quick about Eastgate. We're a much smaller MPO. In our urbanized area, we have about 550,000 people. So it's not the scale of Philadelphia or Boston by any means. In addition to a metropolitan planning organization, we're also a council of government. So we have the EPA side with the area-wide water quality. We're an economic development district and a local development district. And we do this all with about a staff of 15. So each of us, breaking out of our silos and seeing where health fits into each of these. Just a little bit about our area. We're a pretty distressed urban area, but there's signs of growth. We are lucky to have a strong research institution, so that's bringing some manufacturing jobs in the additive manufacturing space back, and that countering with an aging population as well as pockets of high poverty. Quickly about some of the things we've done as an MPO, and that's, Jim's on the call here. He has a DOT background, so this is really his bread and butter. But new for us is that we did start a planning grant using our planning dollars through FHWA to ODOT. It's just a small planning grant. We allocated $30,000, and we actually got 6 applicants. And why this is exciting to us is it encouraged our local governments to consider how land use and transportation interact in a new way, and it led to a lot of active transportation projects. So We're excited to fund a few of those. We're doing a road diet project. We're looking at a bike share and also like an access management safety as far as ped and bike in a township. So that's new for us, and we're looking forward to helping our local governments as they prepare those grants, and then hopefully those lead to projects that we add to our transportation improvement program in the near future. This last year, we also helped the City of Youngstown, which is our largest member, on a Clean Ohio Trails Fund grant. This is through our Ohio Department of Natural Resources. So definitely look into your state's resource fund, whatever that may be. And there are a few different types of trail funds within that area. And so we were able to support the city in getting nearly $500,000 for a new pedestrian and bike path that will connect our downtown to Mill Creek Metro Parks, which is the second largest metro park system in the nation. So although, you know, as planners, we'd say, oh, it would make sense to connect your, newly revitalized downtown where an amphitheater is going to be built, where there's lots of opportunities for entertainment with a park system. But, you know, we're just getting there now, and we're really excited to be a part of that. We're also working on our main project. The exciting project we're working on is called the Youngstown Smart Network. And so that's to strategically connect the different anchor institutions in Youngstown. And we submitted this as a Tiger grant, and we'll go forward looking for other funding because we were not successful in the last round. But this is exciting because we really haven't pushed complete streets as an MPO before, so we're really glad to put our mark on that. And then that also has transit elements. It helps connect lower income communities more easily to the hospital system, as well as education, and then all those factors that were just mentioned as far as you know, nature versus nurture. If you have the elements nearby, can you access them? And then as safety side, we're working with ODOT on a Buckle Up, Phone Down campaign. Recently, we just had a Don't Text When Driving corridor established in Ohio. Jim, is that the first one in Ohio and maybe the nation?
It is. ODOT, with cooperation with the locals, established a 17-mile corridor, Interstate 80, as it cuts through Youngstown. That's the route that would go from New York to Chicago. But that corridor, we've worked with the Highway Patrol to establish a distracted driver corridor with emphasis on more patrols, more awareness. Again, the first one in the nation, and we're anxious to see the data we get from that. It's only been in play for about 3 weeks, but with the added patrols, the feedback we're getting from the Ohio Patrol is that we've had less accidents out there already, and the ones we pulled over have been less distractions.
Thanks, Jim. And also just the Safe Routes to School program, in the past 2 years, we've become more active participants on the planning grants when working with ODOT on that. And I know in the spring and fall, various staff members have volunteered for walking school buses, and that's a pretty fun way. You know, you get to wear some highlighter gear and meet some kids. And it's also a really good way to see how, especially in low-income communities, how kids experience walking to school. I was amazed the time I went. The route we took, although there were supposed to be sidewalks, they were so covered up that you couldn't even see them, and the tall grass, trash, and so forth. So having that experience and then being able to share that with our local politicians and our mayor, we've been able to clean up a lot of the main routes in Youngstown that kids use for walking to school. As a council of governments and under my work and with the Economic Development Administration, I was lucky enough to be part of Invest Health. Invest Health was under the Robert Wood Johnson Foundation and Reinvestment Fund, so very strong Philly players there. And so this was an initiative to help small and mid-sized cities address health disparities. The Reinvestment Fund and Robert Wood Johnson Foundation has done a lot in larger cities on the East Coast, and they were realizing that those strategies don't necessarily work for small and mid-sized cities. So it was an opportunity over 18 months to meet with funders, government agencies, including the federal government, about what can work for small and mid-sized cities, because we don't necessarily have the philanthropic dollars that larger communities have, and some other resources. So it was a good learning experience for us. We got a lot of technical training on project management, how to stack capital, and looking for ways for those funding gaps for community health projects, and also just basic racial and equity training that we were able to share at home with staff. Like was mentioned previously, this process led us through our community benefits with our local hospitals. And I'm excited that for the first time ever in 2018, our local hospitals are going to coordinate that community benefits plan. And I bring that up because I think that's a real win for us, because we've never really been a part of that process before. But that did come out of this Invest Health, and that we realized that these plans weren't coordinated. And through those, looking at those plans along with the local health department, the counties, we really we started to look into healthy food access, public park access, and comprehensive health education. So with Invest Health, that's more where we focused our time, but it also led to greater partnerships with the hospitals locally. And then we've used this grant to leverage some other dollars. Our community foundation has a children's fund, and even although they used to do more in the education space, helping disenfranchised, underserved populations, they realized that obesity was a great barrier for these children having good experiences. You know, they're struggling in school and home life. And so they started to do active living and more of that, and that kind of led into this investment where they provided $150,000 for 4 parks in the city, providing new, like you can see in this picture, new active like playground equipment. And that's one lesson I really learned from this. Really have the kids teach you what they want to play with. I was all about swings, so when we were putting the grant together, I put in swings, but through the public engagement process, I learned that kids really don't like swings these days. So that was a good thing for me to learn. We also went forward with the USDA SNAP grant, the Double Up program. So this is at a local co-op as well as farmers markets. And then about 6 weeks ago, we had our first launch at a local grocery store. And that is just, it's incredible. I can't quite put the scale on a national level, but we are overwhelmed by the demands of the community and being able to utilize that program. And I want to now get into this healthy community partnership that we've helped launch through our community foundation. This came out of technical assistance with the Robert Wood Johnson Foundation too. So we're excited. We're a steering member on this, and it's and we have about 1.5 million over 3 years to create a healthier metro area. And this stems from these stats you see here, where 1 in 4 residents does not have access to a grocery store, 28% of adults report no leisure time or physical activity, 1/3 adults are obese, and then 80% not getting the right fruit and veggie numbers. We recognize if looking at the county health rankings, we actually have excellent health care. We have a great doctor per resident ratio. We have good emergency times. We have good insurance coverage, but our people aren't healthy. So creating this healthy community partnership is a new space for public, private, philanthropic to meet and talk about these issues. Here you can see some of the initial partners with this. So in addition to the MPO, we have the community development corporations, people involved in the local food space, our major hospital, government entities, and so forth. And sorry, I switched up my slides here. I'm going to go to the next slide. So yeah, here's where we're focusing. We're focusing on healthy food retail, active transportation, and parks and green space. And as a council of governments, we're making sure that we have a staff member in each of these groups. And the healthy food retail, in the past, we've utilized Appalachian Regional Commission funding to have an online portal for people to shop for local foods. We're also looking into other opportunities for more healthy foods in easily accessible locations. And then also an interesting healthy food retail aspect that we might not have considered before as a MPO is that transit need for people to get to grocery stores. We've been mapping that and realizing the travel time for some of, especially the aging senior population. They have really long trips to the grocery stores. And then also, at least for the stores in the urban areas, they're not seen as safe. So we are working with the engineers on making sure there's adequate lighting and so forth to make sure that the existing stores seem approachable. Then active transportation, continuing that Safe Routes to School program. We're also kind of starting a sidewalk squad, at least in Youngstown and Warren. These are disenfranchised communities with limited tax dollars, and recognizing that it is the residents' responsibility to maintain the sidewalk. Many people can't do that. So with the help of the foundation, residents themselves are starting to learn how to pour sidewalks in some of these communities. So that's something we're launching this summer. Hopefully it goes well, but I'm excited to see that happen. And then another simple thing an MPO can do that really makes a difference is communicating who owns what sidewalk. We've been doing maps of, if it's a township or a county or a state, or because most people say, oh, it's the city's fault for the sidewalk, but really it's the property owner. So being able to communicate that as an MPO has been a good tool. And then parks and green space, we have excellent parks. We have got plenty of them, but they're so underutilized. So using models from other cities, like for instance, Philadelphia and what they've gone through to see why people go to which parks they go to and what they want to see in the parks. We're going through an engagement process right now to better program our parks and, like with the grocery stores, make them seem safe. As in closing thoughts, I think the challenging thing about health in this space is that because it's everywhere, it's also nowhere. And that's something we're struggling with as an organization, and then we're trying to get better at is how do we integrate health into all policies. And so it was great to see in the previous presentation, having those health impact assessments. That's something that we're considering going forward. And that also goes into that planning and programming space. Recently, we had an example where the planners knew that the community wanted sidewalks when a right-of-way was available to expand for more roadway. But the engineers didn't know that the community wanted sidewalks. So those types of things we're working on. And then opportunities, really aligning the philanthropic dollars in your community for that programming. Anything you want to add, Jim?
No, I just to summarize, we just found this a small investment of time, a small investment of money made major differences in our communities that we're dealing with. That Safe Routes to School is really one that could just focus on. We were fortunate the state DOT putting money aside, and then we assisted communities in putting the application together and doing the background or the legwork to get the application process through the system, and we made a difference with that. Again, small investment of time and just know how to chase it down and being persistent really made a difference, from a small organization as we are.
All right, thank you.
Thank you very much, Sarah. Really appreciate that. And, now I'm going to turn the webinar over to Patty Elkis. Patty is the Director of Planning at the DVRPC in Philadelphia, Pennsylvania. Patty?
Okay, great. Thank you, Neil, and thank you, NARC, for organizing this webinar. And it's been great to hear about the wonderful work going on in Boston and Youngstown, Ohio. And DVRPC is really happy to join this panel and to share how we're incorporating concerns about health and planning into the built environment. So let me start by just explaining who DVRPC is. And we are the Metropolitan Planning Organization for the Greater Philadelphia area. We've been around. Yes?
Can I interrupt you? Can you share your screen and click OK and so you can see your screen?
I did. Okay. Are we better now? Do you see the screen now?
It's up now.
We see it. We can see it now.
Yeah? Good? Okay.
Yep.
Okay. All right. So DVRPC is the MPO for the Greater Philadelphia area, and we've been around since 1965. We cover 9 counties in 2 states, in Pennsylvania and New Jersey. And within our 9 counties, we have 352 municipalities, over 5.7 million people, 8.2 million jobs, and about a 12% growth rate that we're expected to have up to the year 2045. Like most regions, we have urban, suburban, and rural areas. We have areas of extreme poverty and affluence, and our landscape is quite large, diverse, and complex. So we've been conducting a lot of work that has intersected with the world of public health, air quality, safety, bike and pedestrian, environmental planning, and open space planning. But we didn't directly talk about the positive impacts that these types of planning had on health until about 10 years ago, when what now seems as obvious, that the connections between public health and planning started to reemerge and become better understood. So why should we care? Well, because the CDC according to the CDC, chronic disease is the leading cause of death and disability in the U.S., and it's often related to the built environment. And as Barry also talked about, many health outcomes are due more to social determinants of health, things like education, income, access to healthy food, and access to safe outdoor play areas. They're more due to your zip code than genetic determinants. So as the regional planning agency that is working to improve the built environment, we feel that we can bend these trends to support healthier outcomes for our residents. So about 10 years ago, we started conducting food system planning work. We were examining how food in our region is grown and processed and its impacts on land use, transportation, the economy, and people, and in particular, their health, and the conundrum of the highest rates of obesity occurring in neighborhoods with the least access to food. So these are the areas known as food deserts. This work initiated our interest in further exploring connections between planning and health. Then in 2014, DVRPC was selected as one of 5 agencies from across the country to test the Federal Highway Administration's Health and Transportation Corridor Planning Framework. We ended up conducting a modified corridor study of Haddon Avenue in the city of Camden, New Jersey, using that framework. And the purpose of that effort was to work with planning, transportation, and public health stakeholders and other partners to identify the needs and resources and public health priorities of the communities in the corridor, and then to develop recommendations to improve and promote public health along Haddon Avenue. And along the way, as we did this process, we certainly met new stakeholders and partners, and at the same time began assessing our own internal capacity to include public health issues in our planning projects. So we determined that we could and we should continue to incorporate public health issues into our planning projects, and that we should be more deliberate and strategic about promoting positive change towards improving public health. So the following slides that I'm going to show you are kind of like showing what we've learned along our journey to move the needle on improving public health through planning work. Our first lesson learned is that we can't do it alone. We need partners, and certainly Barry and Sarah and Jim have talked about the fact that they've worked with many partners as well, and we've all expanded our circle of friends, our circle of partners. So we know that health is complex, and it really requires a multifaceted approach to solutions. So, for example, housing in bad condition, we know is a key determinant of health outcomes. But housing condition is a very complex issue. It's related to investment in neighborhoods, foreclosure prevention, access to banking services, previous planning efforts, and so forth. And helping families that are living in poor housing condition requires dealing with legal, financial, social, and medical issues. So we need many partners to address these issues and have a comprehensive approach towards this issue. So We've expanded our network of partners to include public health and allied professionals in government, nonprofit, and academic sectors, and we've worked hard to build on each other's expertise and resources. Our second lesson learned is that programming is as important as planning and building. So we feel like if you build it, will they come? Well, it depends if there's programming or not. And this especially applies to parks and civic spaces that are intended to draw people out for social interaction and physical activity, two things that we know are positive for mental and physical health. So we really work with our partners to program events such as concerts, music, yoga classes, and food demonstrations, and have them planned in conjunction with the new facilities openings to change people's routines and help them become familiar with using these spaces, and also helping people make connections with others that supports their sense of belonging and mental well-being. So our third lesson learned has to do with data, and certainly as planners we love data and we need data. We need it to identify the problems that we're trying to address, and then we need it to evaluate the impacts of our efforts afterward to see if our intervention has had the desired impact. In planning, we're relatively new at evaluating the impacts of our efforts, partly because planning can often take a very long time and it's sometimes difficult to quantify those changes, but we are learning new evaluation techniques from our public health partners. And in terms of availability of data, it's usually available at larger geographies like state and county levels, and it can be more challenging at smaller scales of municipal or neighborhood scales. Census data can, of course, provide good info on social determinants of health, such as income and race, education level, that kind of thing. The 500 Cities Project, which is a project of the CDC and Robert Wood Johnson Foundation, uses that census tract information. It matches it as social determinants of health with health outcomes for 27 different chronic diseases. So that's something to check out if you're working at that scale. So also, if you don't have data at a smaller scale, you might also want to consider working or partnering with a local nursing school. Sometimes they have students that will be doing public health outreach work, and they may be able to go out and survey residents in the neighborhood to help you collect some data. We're certainly doing that in the city of Camden. So the fourth lesson is that there are lots of tools out there to incorporate health into planning, but it is key to choose the right one to achieve the goals and objectives of your project. So at DVRPC, there's been a lot of interest in our greater Philadelphia area about the subject of incorporating health into planning, but it's a relatively new area, and we sense that a lot of people wanted to learn more about it. So we actually brought in an outside speaker to conduct an interactive all-day workshop specifically on incorporating health into planning, and that included how to collect and use data at different scales, how to incorporate the health language into your plans, how to do specific outreach for such factors, and also even how to review site plans for health concerns. And then we also had 3 planners within our region who have conducted community health elements at a county and municipal scale to share their experience. Other tools that we're using in our region, walkability is very important, and so we're doing walkability audits as well as funding them. And we also have a very robust bike and pedestrian counting program that helps indicate what places are being well used and demonstrates the need for more funding to support those efforts. And we are, I think I started to mention that we're doing a healthy community plan element of the master plan for the city of Camden. The 5th lesson is that small steps can lead to huge payoffs. So we know that we're not going to change people's health overnight through planning, but we don't have that magic pill to do that. But we would like to, we do think that we can provide the infrastructure that can lead to lasting change, because small steps can lead to a positive lasting change. So for example, again, back to the walkability issue, we know that's really important to help people be able to walk as a part of their daily routines. So we are doing a sidewalk inventory for the region that also includes a public engagement process for local governments to share their data on sidewalks and for residents to give data on sidewalk condition and use. And then we plan to use this information to help us prioritize further planning and capital funds for investments in sidewalk areas. we've also been very, very fortunate in our region to have a foundation of the William Penn Foundation, who has made a big investment to date, $23 million in our regional trail network that they've given to DVRPC to re-grant to close gaps in our 800-mile regional trail network that we've branded the circuit. So again, by having this network of trails that goes through urban, suburban, and rural areas and connects all kinds of destinations, we can get people out and about and being more active. So lesson number 6 is to don't be afraid to experiment. Certainly quick, low-cost temporary changes to the built environment that make a small area more lively and enjoyable can catalyze long-term change. We're currently looking ways into support more tactical urbanism projects. But in the meantime, we did experiment with a movement break at one of our Healthy Community Task Force meetings. And after sitting an hour and a half, we got people up for a 10-minute movement break that is also accessed at that link on the slide. We had a physical activity coordinator present at the front to also kind of in person encourage people to do this. And it was a little bit risky. We didn't know if people were going to scoff and walk away or actually participate, but you can see from the picture there that everyone pretty much did participate. And we think that those that actually took that 10-minute movement break probably had more energy for the rest of the meeting than those that went out and got the second cup of coffee, which of course we also provided. So lesson number 7 is show me the money. Because to some people, the most compelling argument for investments with public health outcomes is going to be the money saved. And we certainly used this argument in our return on environment study that calculated the economic benefits of protected open space in order to raise more money for protecting more open space. So it turns out that the largest economic impact from protected open space was avoided health care costs from people that exercise in parks and trails. And we showed that our system actually provided $1.3 billion annually in savings in health-related costs due to people's improved health, avoided workers' compensation claims, and avoided lost productivity costs. Lesson number 8 is about knowledge exchange, and this has been really important to us because as planners, we consider ourselves natural conveners, and at DVRPC, we've had a lot of success in bringing diverse groups to the table. So recognizing again that there's this increased curiosity about how planning and health intersect, we created the Healthy Community Task Force about 4 years ago, actually in the spring of 2014. And first we had an all-day event just to bring people together to see what there was to learn. And there was so much momentum that we actually created the task force. And we've been meeting about 3 times a year to date. These are really well-attended meetings. We sometimes get standing room-only crowds of over 100 people in our conference room. And we've covered topics such as equity and active transportation, health and housing, age-friendly communities, climate change and health, civic space and mental health. And this year, we're spending the year of 2018 focusing on racial equity in health with discrete sessions on residential segregation in health, discrimination, trauma, and health, and equity analysis of crashes in our region. And then we're following those 3 sessions up with a 3-part training for Healthy Community Task Force members that will actually help them advance racial equity in their work, in their organizations, and their communities. So they can take what they've learned and learn how to actually execute that in their communities. Lesson number 9 is to incorporate health in all policies as standard practice. So we talk about health considerations a lot, but we want to make them standard practice, not an exceptional or one-off consideration. So we have included language in our long-range plan about healthy communities. We have an ongoing project in our work program, and we have incorporated language on creating healthy communities in our vision statement so that it's part of our everyday vision in terms of what we do when we come to work every day. Finally, lesson number 10 is to walk the walk, and certainly in addition to incorporating better health outcomes in our planning work, we try to do so in our operations so we can walk the walk and not just talk the talk. So I showed the exercise break video, which is something that we use certainly in the Healthy Community Task Force. Maybe we'll use it in other meetings as well. Of course, silly things like putting out soda at meetings, yes, we do that, but we also have a big sign that directs people to the water cooler. And we are on the 8th floor of our building, so we do have a very clear sign right under the buttons that, hey, you can, instead of just standing there waiting for the elevator, you could take the stairs. So we certainly probably walk down more than we walk up, but we do have constant reminders of taking the stairs as a daily thing instead of relying on the elevator. So those are our 10 lessons learned, peppered with some of our experiences at DVRPC and on incorporating health and planning. And a lot of our work can be found at the website link that I list there, and to at any point answer any questions afterward. And now I think I will turn it back to Neil for any questions.
Thank you, Patty, and thank you for an excellent presentation. Let me just take this moment to thank all of the presenters, Barry Kephart, Sarah Dougherty, Patty Elkis, Jim Kinnick, all of you for really outstanding presentations. I'm going to turn it over to my colleague Cameron, who is going to ask or take questions from attendees, and hopefully our presenters will provide you with the answers you need. So Cameron.
Thanks, Neil. So we have around 10 minutes for questions. If you have a question, just type it into the questions box in your GoToWebinar toolbar. We have our first question, Barry. How do you ensure that the costs associated with addressing the built environment are fairly allocated to the cities and towns across your region?
I was on.
You might be on. Sorry.
I think I'm off now. I think we think about it in a couple ways too. We tend to think about it two ways. One is that certain cities and towns in our region have just a greater capacity. In some ways, there can be really good partners for doing some of this work new for the first time too. But often what we're leading from is thinking about which of our cities and towns and which of those neighborhoods really have now or experience the greatest health burden, and often there's a historical basis for why that's happening, whether it be how we've developed, past segregation and discrimination, how we made investments over time. And so those are the places that we're looking, because we don't think as a state that's one of the healthiest in the nation, a region that's fairly strong, we don't think it's right that not everybody has that ability to kind of be at that same level. And so often we're taking that lens to figure out where we make investments, but that idea is that by unlocking the potential of those that may not be doing the best right now, that we get an even stronger region.
Thanks, Barry. Our next question is for Sarah. Can you talk a bit more about the SNAP program and how you use the grant to expand access to healthy foods?
Sure. Actually, the grant might be available right now. Check out USDA and then the NIFA, N-I-F-A. And this was spearheaded by our Community Development Corporation for for Youngstown City, as well as the foundation component of our local hospital system. It took about 18 months to put together, in part because grocery retailers, it was very hard for them because they have to track new information. So I think that was the biggest struggle there, but it really was a matter of having some conversations with local grocers, and then finding that local partner, which was the Health Foundation out of the hospital, to pay that match, which I can't quite recall. I think it was nearly 50% for that grant.
Thanks, Sarah. The next question we have is for Patty. You mentioned how complex the housing situation can be, and you have brought together diverse partners. Have you seen improvements in housing and therefore health as a result of your efforts?
Our role with the housing right now has been more as a convener of people to bring together to work on these issues together. So as a regional planning agency, we've been doing the housing work at a more regional scale, looking at affordability and distance to travel to jobs and so forth. So I think that in that case, again, our role has been to bring these various parties together and recognize that the the issues that come out of living in substandard housing are so complex, and people need to work at it. And how we do comprehensive planning, that there needs to be a comprehensive approach to dealing with people's poor health outcomes from living in substandard housing. So that's really been our approach, and it's I think it's been hard to measure. So I don't have a measurement of it.
Thank you, Patty.
Mm-hmm.
The next question we have is, I think, for everybody. A common theme of all presentations was increasing activity. Have you been able to determine which changes you've made? Determine which changes you have made that have been most effective in increasing activity levels within your regions?
I'll jump in.
Barry. Go ahead.
Oh, sorry, Barry. Do you want to go first?
Patty. I'll just go real quickly. Thanks. Just to say that one, we've recognized that as somewhat of a limitation. So the one piece I referenced, we're actively under a partnership with our Department of Public Health, trying to figure out better ways to measure that. And I would say that we rely upon some recent research, and so there's some good stuff coming out from active living research that really kind of documents the percentage and types of changes you'd like to see. And we kind of looked at them as a really good guide rather than just thinking anecdotally the infrastructure investment will just result in physical activity. So we really look at a lot of the public health literature around that. Thanks, Patty.
Yeah, and I was just going to say that we do have this robust pedestrian and bicycle counting program where we have permanent stations as well as rotating stations, and we've been seeing a big rise in both pedestrian and bicycle activity on trails and sidewalks and other places that people are biking or walking. So we know that people want these spaces. We need to make sure that they're available and safe, and I guess we could apply a multiplier and figure out what those health benefits are. But we have been seeing an increase in this activity from our counting program.
At Eastgate, we don't have the longitudinal data for this yet. It's something that we're considering integrating into our long-range transportation plan. My takeaway is to include people that are representative of the community that you're trying to reach. We've had a lot of programs where people just don't show up. So having the right partners and really seeing, that equity piece as well as racial inclusion is very critical for those, for say, just measuring attendance at health programs.
Thank you all. Our last question that we have right now, just a reminder, if just to type any questions that you have into your questions box on your toolbar. The last question we have is for Barry. Climate change has been impacting Boston in a huge way. How are you using your planning process to address this issue, especially as it impacts the health and safety of the public?
Good question. So one, as a regional planning agency, we try to at least be, I think, as was noted earlier by Sarah, just, or no, maybe by Patty, but just being the role of the convener. And so we've had some opportunities to convene sets of municipalities in our region to both organize around key pieces of work, so large pieces of infrastructure like utilities and transit systems, but also have them kind of share what a lot of their local work is. And we're definitely a fortunate reason where a lot of the cities and towns, as well as our state, take climate change very seriously and have been making a lot of investments in that too. And so we do a lot of organizing around that. And I think from our public health perspective, and I think what's increasingly with some of our local public health partners, have been making sure that the human health and welfare outcomes are more accommodated or more considered in the planning processes. I think a lot of the climate planning typically looks to the natural environment and looks to build infrastructure and doesn't always necessarily take into account how people with chronic diseases, how people with disabilities, how people who are young and people who are very old are going to be affected by it. And so a lot of our work has begun to focus on how do we introduce that as an element of the climate planning process. So understanding who's at risk and why they're at risk, and so developing some framing around that so that we can use that consistently in our processes. And I think it is just a really big piece of it, because I think in both the emergency events that might be climate driven, but also kind of the long-term effects. And so there's increasing base of research that talks about the mental health effects of, again, a changing climate and traumatic events that might come from hazards. And so, yeah, so we're trying to build that in a stronger way, knowing that a lot of attention has already gone towards our kind of natural resources and infrastructure.
Thank you, Barry. I think that's all the questions we have right now. So, Neil, I guess I'll pass it back off to you.
Thank you, Cameron. Great set of questions. Thank you for addressing those. And excuse me, I just want to give a big thank you again to Barry, to Sarah, to Patty, to Jim for outstanding presentations and excellent information. Just so you know, the webinar is recorded. So if there's anything you would like to get or to hear again, you'll be able to access the webinar through our website. In addition, the presentations are it can be found on the GoToWebinar control panel, and you can download those. So hopefully you found this as interesting as I did, and we'd really appreciate any feedback you have, comments. Feel free to email them to me at neil@narc.org. And with that, I'll just again say thank you to all, and we'll close the webinar at this point. Thanks a lot, everyone.
Thank you all.
Okay, thank you.